Welcome, everybody, to the Blueberry Pediatrics Podcast. I am joined here today by two of our amazing pediatricians, and our topic of interest to chat about, based on parent feedback today, is pediatric asthma. Let's go around introducing ourselves. I'm Lyndsey Garbi, pediatrician, and one of the founders of Blueberry. Kristen, you want to go?
Sure. I'm Kristen Borchetta. I'm also a pediatrician, and I am one of the physician leads at Blueberry.
And I'm Debbie Gage, a pediatrician, also an employee at Blueberry.
Great. Thanks for joining us. I have the best, most well-studied doctors on our roster today here with us, so we can dive in and hopefully answer questions or things that you might be wondering about asthma. A lot of things are changing, but why is this so important? Let's start with that. Pediatric asthma is the most common chronic disease of childhood. In the U.S., it affects approximately 6 million children, which is 8 to 10% of the pediatric population. It is the most common among young children, especially under 5 years old. A lot of parents listening are probably like, I know this. Some children might outgrow it. Hopefully they do, but some do persist into adulthood. All right, so let's chat about risk factors first. Like, why do kids get this? Who's more likely to get it?
Sure. I mean, family history plays a big role, right? If a parent has asthma, that doubles your risk. And certainly if there's increase in allergies or eczema, that also increases your risk for asthma.
Yeah. Also, things like exposure to tobacco smoke in young kids increases the chance if your child was born premature. Living in an area that has a lot of air pollution, those are kind of like the outside factors that can also do it.
Also RSV in infanthood.
Right. In infanthood, and obesity.
Great. Okay. And so when it comes to the emergency room and things here, actually one of the doctors that I take my kid to, which by the way, I have 2 out of 3 with asthma, knock on wood, the third doesn't also have it. I have it too. It's definitely in my family. Someone who I took my kids to said, do you know what percentage is acceptable to have for children in the ER with the diagnosis of asthma? And it's a trick question because the answer is 0%. We should not have kids needing to go into the ER for asthma in an ideal, perfect world. Obviously, that's not what we live in. And there's always going to be a first time where parents or doctors, weren't aware that a child has a propensity to have asthma. But ideally, we can hopefully prevent escalation and kids getting into dangerous positions and having to go into the ER to handle it. So let's talk about what is asthma to begin with.
So asthma is a hyperresponsiveness of the airways and the lungs that leads to inflammation. And then this inflammation causes the airways to narrow and produce excess amounts of mucus along the airway. And that typically causes some difficulty breathing, especially with exhaling or breathing out. It can cause retractions, which is just the increased work of breathing, and kids can cough, wheeze, or feel like their chest is tight, or even feel like they have difficulty breathing.
In reality, what that looks like for our patients is a kid who is breathing really fast. Their belly's going up and down really quickly. They're using what Dr. Gage called as retraction. So you can see the muscles in their neck here, their muscles between their ribs going up and down and really working hard to get that air in and out. Also, they could be grunting. They could be not finishing sentences. That's like a very good real world example. They can't string along a lot of words together without having to take a breath. Am I missing anything?
I would just, I think a lot of people think, oh, it's asthma, they have to wheeze. But it's really important for parents to know that a lot of little kids don't wheeze or they can't hear the kid wheezing. So sometimes it's literally just cough that lasts forever after a sickness, cough that just is really bad all the time. So, it doesn't have to wheeze for us to consider this.
Yeah. So a wheeze is like a big trigger word for asthma. Usually it's a sound that we're using to describe our lungs, the lung sounds that we hear with a stethoscope. A lot of parents can always say, I can hear him wheezing. What do you interpret that as usually?
Yeah. Mostly, I feel like a lot of that is the nose. It's that nose whistle that people are hearing. But certainly in a severe attack, you can hear actual wheezing from the lungs, but it's so hard to describe. I think parents always say, like, tell me what that sounds like. And I'm like, I can't mimic that.
Well, and sometimes little kids especially will just let that junk sit in their airway and breathe through it. And that can sound like wheezing too.
Right. So the airway, meaning like the upper airway, like it's all the mucus up here, but it's not down into the lungs. And it's on a wheeze is on an exhale. So if you're hearing them make an inspiratory and inhalation sound, like that's different than yeah, you actually can't hear it, but usually on an exhale without a stethoscope. But I will tell you, as a parent of kids with asthma, I can tell by looking at my kids that they are wheezing. Should I listen with a stethoscope? So I know there's a lot of parents very in tune to just like understanding how their kids' bodies work and what's needed in that moment. So I kind of get that too.
And I think sometimes, since it's so restricted when they breathe out, you can also look at kids and see that like they'll take a normal breath in, but then when they breathe out, it's really short because there's not a lot of air coming out. So it's something to kind of see if you're really looking for those kind of things.
Yeah. The most common trigger when they're very little is going to be a virus and a cold. So that's if you know your kid's sick or getting sick and has a history of wheezing or needing a nebulizer, that's when to be more wary of them needing escalation in care.
Cold weather, allergies, those are other big triggers. And exercise, there's even some people who only have asthma attacks when they exercise and don't have them any other time. So something really important for parents to know.
Mm-hmm.
I actually was not diagnosed with exercise-induced asthma until I was like 20 years old. Everybody said I was lazy, but it made me like hate exercise because I was like, no, I really can't breathe, but nobody noticed it because I never had symptoms any other time.
Yeah.
It happens.
That's so funny and not funny. Sorry. If you think your child's having an asthma attack, let's guide parents on what to do. We know now.
So are we talking about kids that we know have asthma, or kids that we don't know if have asthma?
Either. So they're listening to this, they're kind of aware, they know asthma exists, maybe a friend or their other kid has it. And so they see their kid with symptoms that I just described. What's the next step?
I was going to say, I probably would recommend just getting in touch with their pediatrician to run it by them, let them know what's going on. If they've needed albuterol in the past, it never hurts to try the albuterol and see if you notice the symptoms get better. What I usually tell families, if it gets better for 20 minutes, it might not be it. But if it's better for 3 or 4 hours after an albuterol treatment, then we could be onto something.
And I think, if you don't know that your kid has asthma and you're concerned, I mean, really it comes down to a lung exam. Someone has to get a stethoscope and really see what's going on to really be able to tell.
And should they use telehealth? You want to describe what it's like fielding a visit for that?
Yeah, so definitely symptoms, talking about cough. If they can get a video of the quality of cough, that can be helpful too. Timing of the cough. Asthma usually is worse at night than it is during the daytime. And then doing a nice, being able to look at their chest and see how they're breathing. So we can tell if they're working to breathe or not. That'll help us gauge how urgent it is that they need care. And we can certainly assess before and after an albuterol treatment too, and see if there's a difference.
So where would you say that line is where you would, the threshold to say like you definitely need a lung exam at this point?
Yeah. So I think if they have fever, I always worry that could be pneumonia. So I would want them to have a good lung exam. And certainly if they're working to breathe, it's not mild, but it's more moderate. I want them to be seen. And if it's mild, but it doesn't get better with albuterol, then I certainly want to be seen in that case as well.
Yeah.
Okay.
And I think our first time wheezers too, that's something we have to really think about. Like we can tell they're wheezing. They've never wheezed before. They've never used a nebulizer. It can be tricky because so many viruses can cause wheezing, is it really asthma? Are they going to respond? Sometimes it helps to do that albuterol treatment in person and then get a repeat lung exam afterward to really know if it's responsive or not.
Yeah, absolutely.
Help us.
If they go in and they're diagnosed with asthma, let's talk about what that looks like. So usually it's either your pediatrician or pulmonologist or allergist. A lot of people can do this. You got to know your own landscape. Usually start with your pediatrician and see what they prefer and what they can handle. There are a few things that they could do. Like what we described it's like trial and error. We're going to trial albuterol. If it helps, great. That's because when they're very young, it's very limited ability to use the tools we have for diagnosis. So that's one way to kind of know. The other way is by using these fancier tool called spirometry and finding and getting information of the pulmonary function tests. Have either of you done this or with kids?
Yeah.
I mean,
A lot
obviously,
in the office.
yeah, with your in your office. Did you do this in your own pediatrician offices?
All
We
the
did.
time.
So
Yeah.
you both managed it yourselves and never sent kids
Mhm.
out for it.
Only if they were really severe and couldn't control them. So
Okay, that's great. Okay, so go ahead, you take it away. You're better than me.
yeah. No, I mean, spirometry is really simple. It's a little machine, and basically the kid has to like breathe in and blow as hard as they can into it. So we can't really do it under 6. I mean, I've had a few very astute, smart 5-year-olds who were able to do it, but younger than that, it's just impossible. I mean, there are adults that can't figure out how to do it. I had teenagers that were a disaster. It's not
Are you
easy.
describing the one
Yeah.
where like they have blowout candles?
Yes, we tell them like to try to blow out all the candles, or to imagine. We used to tell them to imagine that like there was a balloon and they were trying to shoot it across the
Okay,
room.
so I did this because I have asthma, and it was you had to raise the balloon up to the sky and then keep it in a straight line till the end of the screen.
Right.
I can't tell you how many times I failed.
It's so
I could not
hard.
It's not
Right.
easy.
the balloon
Yeah.
on the line, and then I would just start laughing at myself because it
Yeah.
was so
Yeah,
ridiculous.
you have to sustain that exhale for a while. You
Yeah.
know, it's hard.
They wanted to kill me. They were ready to kick me out of the office.
Yeah. Yeah, it's really hard. So, it's really helpful. And it was really helpful. I don't know if you ever did this, Deb, but for like exercise-induced asthma or the more mild cases, I would sometimes have kids go and run up and down our stairs, 5-10 times and then come back and do
then
the
do it.
spirometry. So it's, it can be helpful, but it's hard getting them to figure out how to do the testing. Sure.
Yeah.
What are you measuring specifically?
You want to do this one?
I haven't done it in a long time.
Okay.
So you can do it.
Yeah. Basically, you're measuring like the volumes in the lung. So, how much volume of air is inhaled versus exhaled. Asthma is really a restriction in the amount of air that you can breathe out. So what we're looking for is to see if how much air you get out is restricted significantly compared to how much you get in. And there's some other stuff on there too, but that's the biggest one that we're measuring.
All right, so what do we do when they're younger? I alluded to this earlier, but if they really can't do the spirometry test till about 6 years old, like how are we making this diagnosis? Are we making this diagnosis? There's a lot of like gray area there.
I mean, I feel like if we have a kiddo that every time they get a cold is wheezing, and the wheezing or cough gets better with albuterol, they probably have asthma. I'm hesitant to say that until they're around 2. But certainly if it's a kiddo that I'm starting on inhaled steroids for prevention, they probably have asthma. And if I'm doing that and they're over 2, I probably would say that. I don't know if you do the same.
Yeah. And I think especially now, which we'll get into management, but the management of an asthmatic is so much different now. I feel like making that diagnosis is so critical. 'Cause there's so many people I talk to that, the kids like, they use an inhaler every time they're sick, but nobody has ever said that they have asthma. And I think, not to overdiagnose it, but if they have it, I think it's so important to really make that diagnosis and communicate for education purposes, because otherwise it's hard for people to understand what to do, how serious to take it, and how to treat it just, in general. So agreed. And infants, I'll kind of give them time. Maybe it's viral. Let's see what happens. But over 18 months, 2 years old, if it's recurrent, I feel pretty comfortable with the diagnosis.
Yeah.
All right, so let's talk a little bit now about management. There's so many places to begin here. What's the overall goal? I think I suggested what it was in the beginning, but it's really go ahead.
Just to have a normal life, right? Not to have to go to the ER, not to be able to have to sit out of sports, not to be up at night coughing. I mean, our goal is for you to be able to live a normal life without having asthma interfere in it.
Yeah, so having a diagnosis, knowing what to do at baseline, and then how to escalate when the asthma will kick in and get worse and have an exacerbation. And so there's several medications that we use. We want to always minimize the amount of medications we give, and we'll always just make sure that it's titrated for exactly what the kid needs. The 2 types of medications that we use are, there's a lot of types actually. The 2 big buckets are inhaled beta agonists, and those are going to open up the lungs. So I guess put it in a bucket. The meds that are going to open up the lungs quickly, and then the things that are going to open up the lungs long term. Mm-hmm. And that's usually like a steroid. Before we get into the inhaled medication management, I'd love to touch on a topic about oral steroids and why we use it, when we use it, and when we should and should not use it. What do you have to say?
I think that's changing, right? I mean, we used to use oral steroids. If we had a kid that has asthma, we'd use steroids multiple times a year. And now I think we know that's just not good for them. It's not good for their growth. It's not good for their heart. I mean, it's not good for their growing bodies. But certainly if we're in a situation where the child's in bad distress, albuterol is not making a difference, we would do inhaled steroids then. Or if we've been trying to we would do oral steroids. If we're trying to do, if we're doing inhaled steroids and it's been a day or two and nothing's getting better, I think we'd start to think about oral steroids too. I don't know what your take is, Kristen, but.
Yeah, I mean, I agree this has changed so much, but I think, I rarely prescribe oral steroids anymore. I mean, most of the kids I see who need them are severe enough that they usually end up in person. But yeah, if 48 to 72 hours on the inhaled steroids, if they're not improving, I mean, we have to consider that, but, at least since, things changed and now we really, really, are much more aggressive about inhaled steroids, which, for parents, in case you don't, that means like a steroid, an inhaler or the nebulizer. And so, the benefit to that is that those medications go straight to the lungs and decrease the inflammation directly in the lungs where it's inflamed versus a steroid by mouth. Yeah, it's going to decrease inflammation, but obviously it works on the whole entire body. It's not specific to just the lungs. And so I have found that they work really well. And if we get them started early on before the attack is really severe, it makes a big difference. So I always tell parents my goal is that they're not going to take oral steroids more than once or twice a year at the absolute most. Yeah, hopefully not. So
I think it's important to talk about the safety of inhaled steroids too, because lots of families are worried about doing anything that says steroids, right? Yeah. But like you said, it really just acts in the lungs. We don't have to worry about all the other side effects that you read about with steroids. I'd say the biggest one we see is if they're not good about taking a drink or rinsing their mouth out afterwards. Sometimes we see thrush, but I honestly don't see that very much at all. So it's pretty rare, but it, in theory, could happen.
Yeah, sometimes, like what we call periorificial dermatitis, like some irritation around the mouth. But again, if you wipe off afterward, I think that's pretty rare once you know to do those things after you use them. That's
right. And like you said, there's hesitancy about any chronic medication, especially when it's a steroid, but studies have shown it's safe. And what really got me as a parent is that 1 year of inhaled steroid equals 1 course of oral steroids. That was convincing enough to me, and we want to avoid the oral steroids as much as we can. So when parents come to us saying, it worked so well last time, I need them now, there's a lot of things we take into consideration before we're going to give that oral steroid, because there's so many steps in the middle that we can take to try and not give it, because it's not good for them. Yes, if it's life-saving, if it's going to keep you out of the ER, absolutely. But it's not our go-to. There's a lot of tools we have before that.
Yeah. And sometimes when we have to do oral steroids, when we do them, the kids are bonkers on them, right? I mean, they're bouncing off the walls and not sleeping and emotional and irritable. That's hard for parents too, right? So if we can prevent that for the short term, in addition to the long-term effects, that's much better as well.
Yeah. So there's nebulizers, like Dr. Borchetta said, there's a nebulizer and then there's inhalers. Inhalers are usually given with a spacer. And the way that it's delivered is very important, because if the kid's not going to effectively take breaths and get the medication in, then it's useless. So they have to learn how to do it the right way, make sure they're doing it the right way. And usually kids pretty young can actually do the inhaler with the spacer, which is just like I wish I had one. Should have brought it. Is like a tube that the medicine goes in and allows them to breathe in and out and hold it within it so that it gets into the lungs, as opposed to like they take a spray, they don't inhale the right time, it just goes all over. And the nebulizer is tubing and a machine that's just constantly blowing the medication into their airway. And so it's like either by a mask, by a little thing they hold in their mouth, or that's pretty much it.
Yeah. I mean, I think the guidelines recommend, and I know most of us do still prescribe spacers for older kids, teenagers, because I mean, the truth is most adults can't figure out how to use their inhaler properly. I watch my dad do it and he's wonderful, but it's hard. Like, it's hard to coordinate when you're coughing. It's hard. So I think spacers everybody should use them. It's just so much easier.
Yeah. And make sure that it ends up in the lungs and not the back of the mouth too, right?
Exactly. So. Yeah. You're not swallowing it down your esophagus or whatever. So,
right.
Yeah.
And there's a lot of different types of medications. I very overgeneralize it by saying there's 2 big buckets. But if kids have, let's say, mild asthma, you want to kind of go through our escalation in more we'll keep it still like a bird's eye view. But if it's just once in a while mild, we're gonna I'll ask you. You can keep me in line here. So if it's just super mild, the least of the medications we'll give is.
So it depends on their age, right? Regardless, we're going to do a combination of inhaled steroids and albuterol. So if they're little, if they're under 6, the inhaled steroids are once or twice a day, and then your albuterol every 4 hours. But if you're over 6, the newest recommendations are to do both albuterol and the inhaled steroids every 4 hours, and then as needed. So as things get better, you don't do them so frequently. And studies have shown that after doing that about 24 to 48 hours, the asthma calms down and you don't have to do it every 4 hours anymore. So it works nicely together to decrease the inflammation and improve your breathing.
And that's for an exacerbation. So that's when the asthma is really kicking in and getting worse. Right. So baseline, let's go there. So
yeah, I mean, if it's mild, you're not really doing anything at baseline. You're just keeping your inhalers handy for when you need them and when you have symptoms. Once you get to like more intermediate and severe, then often you're taking a steroid inhaler daily or twice a day, depending on how severe your asthma is, to try to keep that inflammation at bay so you're not having flares.
Mm-hmm. And the type of inhaler, so there's the steroids like I mentioned before, and then there's the ones that open the lungs. There's a few types of the ones that open the lungs. Some could be acute, they're usually all acute acting, but some will only last a little while, like 4-ish hours, and others will last 12. And so it just depends on the extent of the asthma to determine the medication the child will need.
Mm-hmm.
All right, what am I
There's
missing?
also other meds, for really severe asthmatics. I'm sure there's some parents out there whose kids are on other oral medications. Allergy control is really, really important. There's some oral or injectable asthma medications for really severe kids. So, if your kid's not getting better with all these inhaled controllers and, you're using them at their max, that's something that usually we'll send you to see a pulmonologist or allergist to work on.
Yeah. And, something actually we didn't touch on yet is that a child who's diagnosed with asthma might not have an exacerbation, but the second they get a cold, because that's likely going to trigger their asthma, even if you're not seeing the asthma symptoms start, that's when you start the inhaled steroids and the albuterol.
Right.
So don't wait.
Don't wait. It'll work better if you do it early. Once it gets going, it's a lot harder, right, to get under control.
Oh, what about the home, triggers in the home, things that the parents can do to avoid those triggers being around?
So certainly cigarette smoke really can put kids over the edge. So not smoking in the house, not smoking in the car. If you smoke outside, changing your clothes before you come back in or putting a shirt on that you leave outside, that can really get asthma going. And then it depends on what the kid's allergic to, right? I mean, if you have a kid that's allergic to dust mites or is allergic to cockroach or is allergic to animals, those things will get asthma going as well. And sometimes you can do okay, you're going along and doing okay. And maybe this is if you have no exposures, but then you have some household exposures. So now you're here and then it doesn't take much to bump you, right? So it's sort of a cumulative effect of your triggers as opposed to just being one thing that can set you off.
Yeah, and if those triggers are there, it's things like long-haired carpet. It's going to hold on to that dust that you should get rid of. Like
ceiling
thick curtains. What were you going to say?
Ceiling fans. That's a big dust trigger. Because, who cleans their fans regularly, right? There's so much dust.
Yeah. And I was going to say like drapery, curtains, those launch a lot of dust as well.
Yeah, anti-dust like mattress casings, pillowcases, that kind of stuff too.
And stuffed animals, sadly.
Yeah, stuffed animals. The toughest one for the kids.
You can wash them in hot water. That helps.
Yeah. All right.
And then exercise, that's the other big trigger. If you know that your kid has issues with exercise and flares, you can actually use the inhalers beforehand, like 15 minutes, 20 minutes before exercise, so that they're able to exercise without getting an asthma attack.
Oh. Great. All right. Anything else I'm missing?
I think the only thing I was thinking when Chris was talking about exercise is I have a lot of families that feel like their kid needs to sit out of gym because they have asthma and ask me for notes to keep their kid out of gym because they have asthma. But I think it's important to emphasize that they need to be able to participate in participate in PE or in gym. And if they're not able to, then we need to be treating their asthma better, right? And if they're coughing at night, that's not normal. And if they're coughing at night, then they need to let somebody know so we can bump up their asthma treatment. Because again, we want them to live symptom-free as best they can.
Yeah, absolutely. All right. I think this was a great primer and education. I hope everyone enjoys it. Thank you so much for joining me, Dr. Borchetta and Dr. Gage. Really appreciate your wisdom and experience. All right. Thank you for tuning in to the Blueberry Pediatric Podcast. Please be sure to subscribe and like. We're here for all your questions and needs 24/7.
Thanks, everybody.
Yeah, thank you.
Thank you all for tuning in to today's episode. Be sure to subscribe to the show for more episodes. And if you love the show, if you haven't already, please be sure to leave us a 5-star review.